I am so excited. This is very exciting for me. Hi, I'm Karen. Great to see you guys. I know some of you were on that last training, maybe all of you, I don't know, but it's so wonderful to see you. And thank you so much for wanting to do this training. Just a quick little bit about me. So I do all these trainings and I talk to people about the importance. I do trainings for people working with folks directly with intellectual disabilities. And I talk a lot about the importance of therapy. And I always hear all the time, but we can't get therapists to work with our people, right? That therapists say they're not trained. Therapists say, oh, I'm sorry, I'm not trained in that, so I can't do that for you. And I hear that over and over again. But then the reality is, if you look at all the universities, all the graduate schools and social work and psychology and all, there aren't any trainings in working with people with disabilities. So our poor folks with disabilities are left out on the cold. So I am so excited that you all want to be trainers. Way to go. This is so great. So, so today is very exciting for me. I do a lot of training trainers, but I train them to train in the disability field for people working with folks directly with disabilities. So, and I train therapists and I've done a number, but I haven't trained trainers for therapists. So this is a very, very exciting day for me. So the first thing I want to do is meet you and hear a little bit about, what you do, where you work. You may all work in the same place, I don't know, but also, what, just kind of what you've been doing. So I'm Karen, I'm a psychologist working in the disability world. Who would like to go? Just jump in, unmute.
I'm Mary Willoughby. I work for the Middle Peninsula and Northern Neck CSB as an outpatient therapist.
Oh, wonderful.
Hello, everybody. My name is Brianna, and I'm an outpatient therapist at Chesapeake Integrated Behavioral Health Care.
Yeah.
Hi, I'm Liz Herner, and I work for Middle Peninsula Northern Neck CSB as a mental health outpatient therapist.
Oh, great. Who's next? Portia?
Yep. Hi, I'm Portia Porter, or Dr. Porter. I am a supervisor at Portsmouth CSB over the same day access program. So I'm an assessor and a clinician.
Fantastic. All right.
I'm Karen Bailey. I am the clinic clinic manager at Smithfield, and which includes just integrative care as well as outpatient counseling.
I'm Christina Davis, and I am an intern at Western Tidewater CSB.
Oh, great. And there's somebody over there, and we see her ceiling and a lovely lamp. This is the Zoom world, and we know Gabrielle. So I have to thank Karen, because Karen has actually made all this happen. Thank you so much. So Karen reached out to me for a regular training and then reached out again and made Gabriella help her. So I thank Karen and Gabrielle, because the two of you have really made this happen. So I'm so excited. We're not sure. Okay, there's somebody else. Okay. And we weren't able to connect with one person. I think they're having audio issues. And someone just joined us. Hello there. How are you?
Hey, good morning.
Nice to see you. And we are just introduced ourselves. You're right on time, the last one.
My name's Dr. Stacy Fernandez. I'm with Chesapeake Integrated Behavioral Health.
Oh, fantastic. So I was thinking you guys would all be from the same organization. I'm so excited you're not. I'm so excited about this. So I want you to make this your own. I'm going to give you the slides. So you've got a ready-made training. And we'll go through them, but I want to have a lot of dialogue because as I said, you know, I really want you to be able to make it your own. I really want you to share insights you have. And I'm going to go over what points I think are important for training therapists. But the reality is when people tell me, and it's not you guys because you're so cool because you're here, but when people tell me I'm not trained in working with people with disabilities, sometimes I get a little snarky and I say things like, well, are you trained in working with humans? You know, because, hey, hello. So, and a guy named Brian Talent says that this is not a specialization and you're not going to find training for it. You know, I taught for many years at University of Baltimore in the graduate psychology program. And I kept saying to them, you know, I should be teaching a class and doing counseling with folks with disabilities because you're going to have people that are going to be ending up working with folks with disabilities. I could train them in doing the behavioral piece that everybody wants them to do. We can talk about the counseling. And they kept saying, no, we won't have any interest. Keep teaching the trauma stuff, right? There won't be any interest. And then sure enough, when we finally, I quit and I said, you know, it's too much with my full-time job and everything. They said, well, is there something you wanted to teach? Yeah, counseling people with disabilities. So then I did it. And so they put me in the summer class. I said, okay, that's the last class, but if you want to keep that going, I'll come back and just do that because that's my heart. And we had 10 people sign up for a summer class. Thank you very much. That's a lot of interest. Oh, well, the world will change. It definitely will change. So here we are. And I've been very excited trying to, you know, penetrate and get wherever we can, you know, just the mindset of let's work with embracing folks with disabilities and offering them treatment. And I see that it's happening, and I was so excited to have some wonderful phone calls with Karen, who's been working for so long with folks with disabilities and very dedicated. And I've heard from many people, and I did a series of trainings in Virginia, that you've just been through quite a process of folks joining you, right? Folks kind of being pushed out of different settings and here you are. So I think your trainings will be very valuable. You know, go ahead and charge lots of money for it. You got my blessings. And so a guy named Brian Talent gave a presentation about doing therapy with folks with disabilities, and he's a part of NADD, National Organization for Dually Diagnosed, and they have some really great conferences. I really appreciate them a lot. And they've done a lot of work to really talk about the mental health needs of folks with intellectual disabilities. And his work is great. He runs a clinic in Colorado and only working with folks with disabilities, predominantly children. And he does therapy. It's all therapy. He doesn't do anything behavioral. And they do really cool stuff. And what he says is something that I really love. He says that doing therapy with people with disabilities is a cultural competency. So you can think of yourself as training in a cultural competency. You know, this is a cultural competency. It's, yeah, the disability culture is a different world. And what I'm going to do in the next 4 sessions is I will show videos and we can send the links to you, or we can just post them, because I think it's really helpful to have the voices of people with disabilities as a part of it. And I know we've done that before.
I have too. I have a sheet that I have, but if you guys are not.
So I'm going to share my screen. And oh, I'm going to ask Gabrielle to let me share my screen. Thank you.
Oh, sorry. Hold on.
No problem. No problem. Okay, thank you.
It's got to work.
And here we go. Okay. Can you guys see my screen? Can you see the screen?
Yes,
Yes.
ma'am, we can see it.
Thanks a lot. And feel free to unmute and talk. And so I'll go through a portion of it and then we'll stop and talk. And I'll go through a portion of it and then we'll stop and talk. So therapeutic supports for people with intellectual disabilities. There I am. So, you know, taking credit for it, but you can say it's yours too, but it's you and me together. And basically my first slide as what I do that I think is very helpful is let people know that this is a very traumatized group of people, that you're working with folks. And I usually don't have so many words on my slides, but I figured it would help you because you really can just, you know, tick it all off on this slide. And it's really important that we talk about each thing so that there is so much abuse of people. So there was a report done by the Spectrum Institute, and they surveyed over 7,000 people, 70% of people with, only people with disabilities, 70% said they were victims of abuse. And they talked about sexual, physical, and financial. 90% of them said it was on multiple occasions, so it was ongoing. Only 37% reported the abuse to the authorities. So let's take that for a minute, you know, think about that for a minute. Okay, there's all this abuse going on. 70% of people with disabilities reported having been abused, and 90% of that 70% said it was ongoing. That is tremendous. So we want to emphasize to therapists, when someone walks into your office, you know, and they're there, maybe their staff have brought them or their family has brought them, you can probably bet on the fact that there has been some kind of history of some abuse, right? Because this group that they surveyed, these are people who could speak for themselves or had family members who could speak for them. So this doesn't even include people who don't use words. So we know that there's a lot. And then sexual abuse is just, there's just so much. So there's a really important NPR series on the sexual abuse of people with intellectual disabilities done by Joe Shapiro. Joe Shapiro is a wonderful, wonderful guy. And he wrote the book, No Pity, a really great book. And he lays out the history of folks with disabilities, and he really focuses on the institutions. And he went to the Bureau of Statistics and he asked them to analyze of all their, you know, all the police reports and reports of sexual abuse, how many people had intellectual disabilities. And they came back to him and said, you know, it's people with intellectual disabilities. Sorry, I'm having one of those mornings, Monday morning, are 7 times more likely to be sexually abused than those without. Wow, right? And in that series, you can see it in the NPR archives for January of 2018, Joe Shapiro's piece on sexual abuse. And in that series, person after person after person tells the story of horrible abuse, or family members tell their story. And it's just heartbreaking. But probably those of you who have worked with folks with disabilities have heard such stories as well. That's the tragedy, right? So we want to let people know that a lot of times someone will come to you presenting one thing, but really there's a history of abuse that they may not even be talking about. I have actually worked with people that I've worked with for 1 or 2 years before they opened up about being, one person was sexually abused in an ongoing way by her biological father, another a stepfather. So many that didn't want to tell me at first. And it took, and maybe this is just reflection on me not being that great of a therapist. That's a real possibility. But also that they were so afraid, because what I've seen traditionally is such, people are just intimidated and manipulated by the abuser. I mean, we see that with folks who don't have a disability, and we see so much of that with children. But I heard story after story where the abuser would say, well, I'm going to hurt you or hurt your mother if you tell. And then maybe it was a boyfriend or somebody. And then I've also heard stories where it was a stepfather or even a biological father that said, well, if you be a good girl or a good boy and you don't tell, we'll go for ice cream every Friday, or we'll do, they got rewarded. But underneath, still lots of fear. So people don't open up immediately. People don't trust immediately. And sometimes it takes a lot of time before you start hearing those stories. The Bureau of Justice released a report in 2017 saying people with disabilities were 2.5 times more likely to be the victim of violent crimes, and 40% more likely to have the perpetrators be someone they know. So that's really tough. And that the violent crimes, right, are very high. And then the social trauma is very real. And I'm going to show you a video that I show a lot with that. So folks being bullied, folks having, just being called the R word, being made fun of. So what I do when I do the training is I always ask people, do you remember being abused when you were not abused? Do you remember being bullied? I'm sorry, in like 6th or 7th grade, right? Do you remember someone that picked on you? For the girls, there's always a mean girl, right? There was a mean girl everywhere you went back in middle school or junior high. So I ask people if they remember being bullied, and everyone will say yes. And then we, first of all, I comfort them, because those bullies, most of them peaked in high school and the rest has been downhill. And they're sitting on the couch drinking beer, talking about when they played football or when they were the cutest cheerleader in the whole team. Whatever, right? And now look at all these wonderful people. Look at yourself. You're professionals. You're great. I always build people up after I make them remember being bullied, because it's not very nice, right? But the name calling, the verbal abuse. And then I have them think, so we can do this right now, think of somebody in your school who had a disability. What did they go through? Do you remember? Do you remember seeing them being picked on? What can you imagine that they went through in the lunchroom, right? In gym class? And then how about in elementary school? What was recess like? How many times were they called names? And, all different stages. So when working with folks with disabilities, my experience is that bullying is a big piece of trauma that really needs to be processed. And a lot of folks are really stuck with it. I've worked with a number of people who have nightmares, repeated nightmares about being bullied. And they're in their 40s, 50s, or 60s. That was so traumatic for them. And now in the world, we've seen people, commit suicide as a result of bullying, do homicidal acts as a result of bullying. We've seen all kinds of things. So that bullying is really impactful. Exclusion and the psychology of exclusion causes physical pain, studies have shown. And being excluded and being rejected are actually very traumatizing. Trauma of institutionalization. And that's something that you might really want to address. So maybe we can look together at a couple of videos, because if you're working with older people and they have a history of being institutionalized, you can pretty much count on the fact that they've had a lot of trauma. And I think you already know that. but we can even show a small clip of like Willowbrook by Geraldo. Also the trauma of repeated foster care placements and physical abuse and neglect. So I'm going to show a video. I like showing videos because I don't have an intellectual disability. I have a lot of issues. I really do, but that's not one of them. So if I can have the voice of somebody with an intellectual disability, it does make a difference. So when we talk about the bullying, I want you, like this slide, you're going to spend a lot of time on, right? It's really full, and you can, like, I would assume that those of you who have worked with folks with intellectual disabilities have heard stories about being bullied. Karen, I know we've talked about the fact that you heard a lot of stories of sexual abuse, a lot of stories of folks being bullied as well. And then all of you, with all this deinstitutionalization that's gone on, I'm sure people who have that institutional trauma will cross your path if they haven't already. So let's look at some things you can show. Here we go. Okay. I'm going to take a minute here. I might have to stop and start again, being myself. Okay. And let me see. Okay. So I like to show this slide, and here's what, or this video, and here's what I say when I do it. There's a reality show called Love on the Spectrum. Have you guys seen that? It's great. And they're all from Australia, and they have very supportive families. And they're people who have, they're on the spectrum, but they've had really a lot of support. And here they are, you know, the whole show is about finding relationships and finding love. So already their families are okay with that, which is not always the case either. And, but people are opening up here about their history of being bullied. And I think this is really important to show, because it shows you that everybody, that so many people with an intellectual disability, not just those who have been in institutions and not just those who, you know, have very involved issues, but just about everybody has had some kind of bullying experience, because kids are cruel and they carry it with them. So some of the folks here really give an incredible description of it.
Do you think it's harder for people on the spectrum to find love and companionship?
Yes. We weren't born with manners like you are. We have to learn all our social cues.
I tend to overthink things a lot.
I have trouble with reading people's emotions and body language.
Too sharp noise can harm my brain.
I do have trouble socializing, maybe making decisions.
I have social anxiety. It's like you're in a room with lots of people and you're told that one of them has a knife. And if you talk to them, they will stab you.
It's like being in a transparent box. No one can hear you, no one can, well, they can see you, but they can't interact with you. You can bang on the wall, but you can't get out of it, so it's very lonely being in the box your entire life, because no one can get in and you can't get out, and no one can understand you.
I just want to share my life with someone very special, and to show her that my disability is not an obstacle, that I'm capable of falling in love.
When I was a kid, I actually found it difficult trying to be friends with others.
I've been to 3 schools, so I always get bullied all the time.
There'll be pushing, there'll be name calling, there'll be people trying to take my hearing aid.
They figured that I was disabled, so it's easier to pick on me, I guess. Pick on the weak.
Well, I would just say in high school, it's more like I was just treated like dirt. There were these few girls who, they said I should ask this person out. I didn't realize it was a complete setup just so they could just reject me, just as a way of mocking me, really.
Didn't tell my mum that I got bullied because I always get these bruises on myself and that. Yeah.
I just wanted to get out of school, you know, just couldn't take it anymore. I had to get therapy because it was really dark times then.
Does it still affect you?
Yes, Oh yeah, the scars don't go away. The negative thoughts.
I think, being bullied have made me who I am. And if I wasn't bullied, I would have been someone completely different.
My autism, I feel it's what's given me my creativity.
It is harder having a disability and going through life with a disability, and you got to keep moving on with life. Like a phoenix, rise up again.
Because I've got a disability, I'm on the spectrum, people are always going to look at me as different from them, and I know I'm different from them, and that's fine. So if we're all the same, the world would be pretty boring.
Wow, right? So let me stop sharing for a minute. And I mean, that's so short and so sweet, but it says so much. You know, you can really see the trauma of it.
Karen, how do you watch that? Where do you see?
Okay, so I'm going to give you the link. Should I put it on the chat? That seems to be the right thing to do, right? Okay.
Can you just email out like a list of all the links with
You
the
know what?
slides
That's what I'm
when you
going to
do
do.
that?
I think that's easier because
That way it all stays in one place and then we can add it. And if you could even send out the slides in advance next time, I could be writing on them like as you go through it.
You know what? I can send them. We'll have a break and I'll send them then. Can I send it, Karen? If I send the slides to you and then I'll send, then you can be.
Gabrielle probably has everybody's list.
Okay.
Everybody's
Gabrielle. So for the rest of the trainings, yeah, I should have done that ahead of time. For the rest of the trainings, you'll have the slides and you can make your notes on the slides. And
You're
then,
doing good, Karen.
All right, thank you for all that. Thank you.
We're learning together.
This morning, I'm like, oh, I should have sent this out. But so we'll send it. I'll send them out today. And I will also make a list, an ongoing list of all the videos I show you. And then I'll send you one long list of all the videos. Because there's so much cool stuff out there, right? And I think it's really important for us to see that. And how many of you are interested? Would you be interested in showing a video about the institutions? So you're interested in the one about being bullied, and I'm glad about that. I got a ton of them. Are you interested in looking, do you feel like the people that you're working with and the folks that you're training to work with folks are going to be working with people who are older with that institutional background? Okay, great. So what we'll do is I'll pull up, because I don't usually show it because in our field, everybody's seen it. So I will look at some of them and then maybe when we take our break. And then I'll have one for you when we come back. So we'll email everything. That's good. Thank you.
I think videos are helpful because I don't know about the rest of the rest of you guys. My unprofessional colloquial. Anyways, I don't know about everybody, but I just feel like a lot of the staff that I work with, it's not so much that they're disrespectful to developmental disabilities, but they really I think compassion and almost relaxing is mostly, there's my 2 point to it. And sometimes seeing videos that recognize that they're people. I mean, I know that sounds almost elementary, but sometimes I feel like we're so much more aware of their disability that we're not really embracing their humanity and enjoying and recognizing that they're people and that they may process things different, they may sound different and struggle in differently, but at the same time, they're people and they feel and they hurt just like the rest of us. So I think sometimes seeing those videos makes us, help people kind of smack out of their, I'm kind of sassy sometimes, because smack out of the way of, I don't know, like things are different for them or some, or they get afraid, and this kind of takes the fear out of it of they're just like us. They just need a little extra help because they can't get their voice out as much as we can.
Thank you. You're so right. And thank you for saying it and for putting it that way. You really hit the nail on the head. Like when you get beyond that disability, there's a human being going, oh my God, I've been through so much, right? Life is hard and I need support. And then so often in the disability world, what we do is just look at their behavior, put them on a behavior plan, and it ends up shaming people. And people have trauma from their behavior plans.
And what I understand from the research I did, is that back in the olden days, that's how, meaning like before now, I'll say like maybe 30, 40, 50 years ago, they almost like any reaction that a person with intellectual disability had, in autism as well, that's how it was almost like everything, it was like one big package. So if I had an intellectual disability and I start throwing things, oh, it's just because of your intellect, because you're limited intellectually, that's why you're doing it. Well, there's a truth to that, because I can't communicate the way most people can. I can't articulate. I don't understand it as easily as maybe somebody else. But that doesn't mean that I don't have, but it doesn't, that's how, I think that's how we divorced developmental disabilities from mental health issues, because we just almost like made it one big blob that they have these struggles, and then we can dismiss them. But if we say, oh, they're just like us, they just have some limitations, then we realize that they need processing. The therapy is helpful for processing emotions and recognizing that it is hard and it is stressful at times for them because they can't express it and they don't understand. It's very confusing, and that's where we are the best help for them.
Yeah, thank you so much. I'm wondering, as I'm listening to you, Karen, I mean, this is such an important point. Should we have a slide that says diagnostic overshadowing? Just to,
oh, that's good.
Why don't I do that? That just says, hey, for so many years, they've looked at this person and all they've seen is intellectual disability. They haven't seen the whole person. They haven't seen sometimes the depression, the anxiety, the trauma.
If people are doing things like, how like back in, that it's typical for autistic people to like maybe movement of their hands, or they rock. And before, I think it was almost not looked at with compassion. It was more looked at like, I don't know what to do with you, versus the recognition that if I'm like this, it's because I'm anxious and I can't, something scares me, something's wrong. It's not always, but before it's always been seen like punitive, and that's not appropriate. And so then they get misunderstood, and then we misunderstand them when there could be a lot more progress and just more compassion. I understand, oh, it's because of this, or, oh, I'm alerted because you're acting a little, you don't act like yourself. Well, when I don't act like myself, people who care about me say, what's wrong, Karen? Are you, but, I mean, that's the kind of compassion sometimes we need, is just like sometimes helping people calm. And so that could be that way. I might have a slide now that I'm thinking about it. So while you're looking,
yeah, no, that's okay. I'll just put the words diagnostic overshadowing on a slide. It'll take 2 minutes. And that way you guys can do it maybe after we talk about the sources of trauma, we can just put that on there. So, because the reality is that the trauma is always missed with folks with disabilities. Nobody gets, unless they were horribly attacked or raped, and everyone knows it, they almost never get that diagnosis of PTSD when it's so frequent and it's always there. And then even people are constantly missing the depression, the anxiety, a lot of the medication, the psychotropic meds, people are medicated for behaviors, which is so wrong, as we know. So, and then they throw in other bipolar, other schizophrenic, but really it's addressing the behavioral issue. And there's the overdiagnosis of schizophrenia. And I'm not sure we should get into that, but I have a slide that I did not include from Bruce Perry, because he talks about the state becomes a trait, right? So that the people look at the state is exactly what you're talking about, Karen, the state that they're in, and they're like, oh, that's who they are. That's their problem. Oh, they're bipolar, or oh, they have this behavior problem, when really they're in an agitated state. But I think actually what we're going to do is also I'm going to break down the symptoms of PTSD as part of this training. And then you guys can go through that in the context of people with disabilities. It'll help with everybody you're working with, and you probably already know it. You guys know it all. But in the training, That way you can help the therapist kind of spot that they're looking at something more than just, a little bit of anxiety or a person with a disability not being able to express themselves. So this way I break down those symptoms. So maybe that will, but I do like the idea, Karen, of what you're saying, that diagnostic overshadowing, how people aren't seen as humans. Here's the person with a disability. They're not seen for their issues, their struggles. I always say when their IQ is below 72, every issue becomes a behavior, right? When I go off, oh, Karen, you've got some issues. When somebody with a disability goes off, they have behavior problems. And people feel very stigmatized. We'll address that too. Okay, so we'll go back to the slides. Okay. All right, so that takes in a lot, and we're looking at, and I will come up with the slide for the institutionalization, because I think that's very relevant for where you guys are. Oh, I'm sorry. It always just pops up to have the captions. So next slide. I like to say assumed trauma, and that's what you're going to be dealing with when you're doing therapy with somebody who has autism, who has an intellectual disability, genetic disorder. There has been some trauma somewhere, and we just made the case for that. And there's betrayal trauma. We see a lot of folks who, thought that they were in one situation, found out that they were another. For me, and I'm sure at some point you'll have stories, or you already have stories, when you do crisis counseling, if somebody is referred to you because of a sexual assault or a rape, that so much of course, the assault is a trauma. It's a terrible trauma, but then the betrayal of it, because often that person was told, well, I'm your boyfriend, I'll be your boyfriend, or I'm going to marry you. And at least in my experience doing therapy, that betrayal trauma. And Bruce Perry talks a lot about the fact that betrayal trauma is a thing, and it's an issue. Folks get betrayed, folks get hurt, folks get lied to, folks get tricked. And we know how that impacts people without disabilities, but there's just so much of it that goes on. The rejection, so much rejection that we see, and that's its own kind of trauma. Social exclusion and the impact of loneliness. So, and you can elaborate on those. I mean, we all know what it's like to be lonely, probably you guys look very together. You may not have been excluded socially, and I used to have a quote here that says, not invited to the party, but I thought maybe it was too superficial. I took it out. But all this is a type of social trauma, right? All these things. And then I go to the concept from Francine Shapiro that I like to talk about, big T and little t traumas. And the reason that I talk a lot about this is it's not news to us, right? We know the smaller things are very impactful, but whenever I do trainings, people will say to me, oh, I can't believe those little t traumas you're right. I never even thought about that. So I found that in terms of training, if you can point out to people, process the small rejections and the small hurts, support people with whatever it is that they're going through, because folks with disabilities have often been discounted. So their little t trauma, their smaller traumas, they add up and they have a big impact. But the reality is, in the world of disabilities, people don't have a lot of friends to talk to. People don't have people they can open up to. Oftentimes, they don't get the emotional support, and they don't even get validated for a lot of the things that they've been through. So a lot of their pain and their struggle hasn't even been validated. They've been told, somebody's hitting me at the day program. If your coworker was hitting you, you'd be happy to get them fired, But so many folks sit at day programs and sit in different settings, and somebody hits them from time to time, and the staff say, oh, don't worry about it. Oh, we have a behavior plan for him, or, oh yeah, just, and they come home and they talk about it, and someone says, oh, just ignore him, or go tell the staff. This is not easy to live with, the kinds of things that their coworkers do to them, that their housemates do, the kinds of chaos of often that their environments are. In some of the programs are very tough. They're little T traumas, but they're still significant. So people may come to you and they're really struggling with all kinds of things. So we want to validate all of it. And I guess that's the big message from the big T and the little T trauma.
And Karen, I think of trauma not only being like things like that could be totally like expected or like, I won't say expected, but like that are like all like just bad and no one should ever have to go through that kind of stuff, but also things like losses that come through. Like I think of when a client is close to a staff and that staff have they leave the position for whatever reason. It may sound like, when it's always a loss when you like that someone's helpful for you, that's a professional in your life, but it's really different when they're like the closest person you have, because that you trust and they treat you like you're special. And I feel like sometimes that loss is kind of like can easily be glossed over because you're getting cared for, like the people around you care for. And it's not that they don't have to be abusive or mean. It's just that you're human. And I feel a loss when I lose if my staff changes, or like my coworker that was my friend leaves. And yet I have other people in my life, but for them, especially if they're in a home or if they're in a situation where they're limited in their relationships, which is most of them, it just makes a big difference. So I was just kind of adding that to it.
I think we should do, I think I don't have enough on grief. So what I usually do, and we collaborate, because, and I think I always do lots of grief counseling, because staff turnover is grief, right? And that's a little T trauma, that's a big T trauma.
Absolutely.
Yeah, or you can just talk about it there, but the grief piece, grief and loss are so critical, and doing that grief work is always central to the work I'm doing. And I do address it later on, but I think maybe we should hit it now too. I think that grief it's a big T trauma. So then I really love that. And the loss is so impactful for people with disabilities. And I think that's a good thing to do to train therapists. Look for where they might be grieving and how that needs to be addressed. So I have on my website, I have a lot of materials that you can share with people to use if you want to. You don't have to. But there's something called the Goodbye Book that I've been using for many years, and I have a lot of people using it in different places now, for adults and for children. Just a little workbook to honor who you've lost. And we found that to be really helpful as well. And maybe what I can do is I can actually send that book we're coming up with more work for you, Gabrielle. I'm going to send you a ton of stuff to distribute, because that workbook for processing grief is very helpful. And then whatever else you do to do it, I think it is really important. So there's so much to cover, right? Like, it's going to be hard, but it's going to be great. I'm so excited because this outreach is just basically all you're doing is giving therapists that comfort level, because people are trained. They know they're therapists, right? But you're giving them a green light, and you're saying, like Karen says, like, here's a person. Just go deeper, go beneath that outside limitation, and find the human, and then do what you do. Just do it a little slower. Don't go too fast, and take your language down. I used to have a slide that said slower and lower, but I thought maybe that's a little tacky. I took that out. But that's really the truth, right? So you want to tell people, take your language a little lower, go a little slower, and do what you do. And then try things, add things, because every human is different. Just like when you're working with anybody, you got to take different approaches with different people because different things work. And then you find like, okay, this person's just looking at you like a blank wall when you're doing this one thing, but then they kind of light up when you have another approach. So then you do that approach. Okay, so we'll go back to sharing. Can you see the slide? Yeah, right. So then I thought it would be important for us to address the disasters and the event-based trauma. And here's a chance where you can talk about COVID. COVID has created incredible isolation where people have been really, really, you know, have had a really tough time. Been lonely, haven't seen family, or many haven't seen friends. We had so many legitimate fears because there were a number of people with disabilities who actually did die from COVID. I know in Maryland, we lost close to 50 people with disabilities. I'm working with another agency right now in New Jersey and New York. They have branches there, and they lost 10 people within the first 3 months. It was boom, 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 you know, being in that New York area. So the deaths, there have been staff who've been lost, people who have lost relatives. So this disaster and event-based trauma. I also have natural disasters because some areas have more than others, and negative events that people maybe, you know, like there was just such an impact in New Orleans with Katrina on folks with disabilities, right? Some folks became homeless. The group homes were destroyed in some cases. So we don't always think about the impact of disasters on people with disabilities and how horrific it can be. So that's something I address here and something you can make a reference to. I talk about the Bucharest Early Intervention Study because so many of our folks may have had that history of being neglected, born into a situation where there was drug or alcohol use and there was neglect, or, you know, just neglect. There's 100 different scenarios of neglect. So Nathan Fox went to Romania, and he did this study where he took half the kids and put them in a foster care setting where they got more nurturing. And then the other half were in this orphanage, and he left them there. So he just randomly picked half of them between the ages of 6 months and 31 months. And, you know, attachment theorists would say the damage is already done. They're taking kids 4 or 5, you know, 3, 4, and 5, the damage is done. Even before 6 months, the damage is done. But they had some really significant results of the kids that they placed in the foster care and who got nurtured and really got a lot of attention because they worked a lot with the foster care parents on nurturing skills. 55% of those kids left in the institution had some kind of Axis 1 disorder versus 35. Emotional disorders, 49 versus 29%. Behavioral disorders, 32% to 25%. And then this is very significant for me. Those left in the institution, the average IQ was 73 versus 85, a 12-point difference in IQ. So here's the thing is that when you are working with somebody with an intellectual disability who was dropped off in that institution when they were very little, that trauma and that lack of nurturing at those critical developmental periods, that in itself lowers the brain's ability to function. So people get diagnosed as having an intellectual disability when in fact they didn't get the stimulation, they didn't get the interaction they needed to be wired up correctly, and they could be very smart. And in the disability world, I always ask people, do you know somebody with an intellectual disability who's really smart? And people always say, yes, everyone raised their hand. I said, now, do they have a trauma history? So you could see where the trauma or the neglect really impaired their cognitive functioning. So oftentimes people wouldn't even have that disability if they hadn't had that total neglect and you know, also abusive situations. So that kind of opens folks' eyes too. You know, they've been in chaotic homes, parents with drug and alcohol issues, repeated foster care placements where they're not getting the education, they're not getting the nurturing, and residential placements where people often do get neglected.
I
So
think that's really true, Karen, that often people will assume, I guess, I don't know what you guys were taught in college, but I almost assumed that 90% of ID came from like genetics, just it happens. But it isn't. I mean, there are that is a thing, but it isn't as much. It really is the neglect affects intellect, abuse and neglect affects it. All those things that you're sharing really do make a difference, and that is, I guess, a different view of looking at it versus like couldn't be helped, because there is things, and of course, if the mother has used drugs and alcohol and that sort of things, it makes a difference too. But I guess in the past, I just have it's all been seen like in a like one way, like once the baby's born, they have it or they don't, and it's not quite.
yeah, there you go.
I like that study. I always like showing the brain scans of those Romanian orphans to families and being like, this is what trauma does. These are the areas we're working on. And like, I've shown that to so many families and it's helped them take it from, they just got to get it together to. So I also want to show them that, like, yeah, you say your kids belong in a residential system. Let's look at this.
Wow, I don't have that slide. That's wonderful. I need to find that. That's great.
I'll have to try and send it to you, but yes, I love that. And then I really like showing that brain scan slide to them. I'm trained in parent-child interaction therapy, and so I can see big differences in how kids even attend school from working on that attachment with them.
Oh, that's great.
Fascinating. So that's pretty cool.
This is right up your alley, and that would be wonderful to see because I have another slide that I didn't include with his findings, like the gray matter shrinks in that brain, right? It's and there's also more premature deaths. There were more premature deaths, which is tragic, right? And there's less brain activity with the EEG. There's so many things. I'll have to put that back. I'm going to work on these slides and then because I want to put that slide back in there. Oh, now I'm getting excited. I'm sorry, guys. I'm adding things as we talk, and then I would love to see that brain scan. Add results. Yeah, because I was hesitant about whether to put this in, and then so I kind of changed it up a little bit, but you're right, it's important. And then of course we have to, thank you for sharing that. And of course we have to show the ACE study, right? We always have to show that. Yeah, you know, I do it with therapists because therapists will say, well, where's the ACE study? Right, because we're all used to seeing it. But it also is so relevant when it comes to our folks. Okay, hold on. Here we go. Okay, right, so we have that chaos. And then, you know, pointing out to people, you know, this stuff, the CDC and Kaiser Permanente's ongoing study, adverse childhood experience and all the things it leads to, disruptive neurodevelopment, social, emotional, and cognitive impairment. So again, often this trauma that folks have been through has really impaired their cognitive abilities. I mean, this isn't just like Karen said, they're not just born smart or not smart. It's this lack of interaction or abusive interaction really affects them. Social problems, early death. So, and health risk behaviors. So a lot of our folks are on so much medication, and that's its own training and tragedy. They're going to come to you on 5 or 6 different meds. That's more the norm than it is unusual. And so they're not doing high risk behaviors as much as oftentimes these meds create diabetes and have all kinds of side effects, and then tardive dyskinesia. And sometimes I've had people who've had med interactions and died. I mean, horrible things happen, but these adverse childhood experiences we know, you know, are so impactful. So It's almost 11. Before I go on to the next thing, maybe we can take a 10-minute break. Is that okay for you guys? All right. Thanks. This is so fun. I still can't hear you. There we go.
I enjoy having a smaller group, that it's not a big deal. Like we can all kind of contribute. And it's not so much taking away.
Oh, it's great. And then I love that we're collaborating. This is so important. All right. I'll wait till everybody comes back. And I found a short one. There's so many long videos about Willowbrook and Penhurst and these places. Oh man, this is heartbreaking. Right.
You dismissed us. Gabrielle came back and she said, "Where is everyone?" And I said,
I feel so bad.
She had stepped away before you had.
So we recorded. Oh, I'm sorry. I thought.
No, it's fine. She just didn't know where we were, and she wanted to make sure it was just that we chose. You asked that it was just a break versus something wrong with the computer.
Technology. Yeah. I try, if it's a small group, I like to give everyone a break just to be nice.
It helps.
It does help. Just go get coffee or whatever. Cup of tea. Okay. I guess I'm going to jump back in. So I did find a good, and I want to ask you guys, so do you have a lot of people referred to you who are older with disabilities? Like, do you have folks who have been in the institution coming to you? Or is it that, I mean, sometimes they're in the hospital. So when I was doing training 2 years ago now, that we went to 5 different locations in Virginia, and we had a lot of folks from the hospitals there who were telling us that they had folks being hospitalized who were deinstitutionalized and having a lot of crises. I don't know if you're seeing some of these folks, if they're coming to your outpatient clinics. Maybe they're going straight to the ER. I think that's what's happening. I think they get behavioral services, and then when they have a crisis, they go to the ER. And there's no therapy in between, which we all know as therapists is the most important thing. You reduce hospitalizations that way.
Well, in this area, at least in Virginia, we have a program called REACH that is specifically for individuals with ID and DD disabilities. So when they do go into crisis, they do call REACH. REACH is a 24-hour crisis program, but they're also giving that prevention support and that in-between support. So they do get that therapy piece. But what I've noticed since working with that program is that a lot of people are in group homes, or they're in they're out of home placement, and people have this idea similar to the kind of the point of this training is that, we can't do outpatient therapy with them. And it's like a lot of these individuals would benefit from that, along with like having that REACH connection. So they have someone coming out, but and I just think it's, that's kind of that barrier. And so they will take them to the ER depending on what's going on. Maybe they don't want to deal with them and they want them admitted. And like, well, they need to be admitted. It's like, no, they just need your patience and they need your understanding, and you can work with them. And kind of similar to like the slower and lower slogan, not a big fan of that, not gonna lie. Because I think it kind of drives that stigma about, because they have an intellectual disability, they're lower IQ, they're slower, but more so as therapists, us adjusting how we work with them and meeting the client where they are.
Exactly.
with
That's a
any-
better way to put it, Dr. Portia. That's the way to put it. Right. So meet them where they are. I like that. I'm going to make a slide. I've got a long list. Meet them where they are, because that's really the thing we know how to do with everybody, right? Like, I mean, it's so funny because for years I just worked with folks with intellectual disabilities. And how long was it now? 3 years ago, I joined a clinic, 3.5 years ago. And so I have to work with some folks who do not have disabilities. And there's some folks with chronic mental health issues. And there's not much difference. There's not much difference, you know? And I had done that years and years ago. And then I thought, okay, I'm just going to stick with my people. But now I'm in this clinic. So, you know, I still get referrals. And so many folks have this very similar issues, right? And part of them shut down because they have so much pain. And part of them can't function in the way they want to function. It's very similar.
Yeah, I agree.
And then sometimes they'll be ready. As a community, we have resources for crisis, but when it comes to, when you think of just most clients, when they've had childhood trauma, sexual abuse, etc., it's not necessarily the crisis of the day. It could be but they need therapy. They don't necessarily just need crisis intervention. And I think that's what, you know, the potential that we have as we take this home, quote unquote, to you know, our CSBs and stuff, because it takes longer. It always takes longer when you talk about, you know, getting over a momentary, like being unstable and struggle versus the fact that I was sexually abused or something like that, you know, neglect. Excuse me, those issues take longer to process for anybody, but especially for those who have an intellectual disability or some kind of limitation.
Right. And the tragedy is folks don't often have the opportunity to process, and they need it. They don't have the same circle of friends we have. You know, you have your friend, you call up your go-to person that you can kind of talk something out with. You know, and then they go to the staff, and the staff will just give them a set of instructions. Oh, well, you go ignore them and don't do this and don't do that and do this and do that. So there isn't that processing time. It's very rare. No, and I know the Reach people. So the Reach people brought me into a couple of places. They were wonderful. I forgot about them. They were fantastic. I wish every state had Reach. And I know they used to be START, and START was all crisis. START's great, but it's all crisis intervention. And START is coming to Maryland too, but you don't have as much therapy. So that's where the Reach did make a difference, because they do more of that. But I love the idea. I think it's very important to supplement what they do with outpatient services. That's ideal. So I'm putting my email here too. So this way we can communicate back and forth. If you guys have thoughts of something that was missing or something offended you or something good that you thought of that, you know, hey, can we also include this? Because as I said, this is collaborative. I want you to really make it yours and just be happy. So here's the shortest video. There's some really long videos. The shortest one I could find that's still the impact. There's some short ones, but it's more about Robert Kennedy. There's another one more about Geraldo. So this one is about both of them, but it's very short, and it does show pictures of the institution. So let me show you and see what you all think. Okay. Here we go.
Well, I visited the State Institution for the Mentally Retarded, and I think that particularly at Willowbrook that we have a situation that borders on a snake pit, and that the children live in filth, that many of our fellow citizens are suffering tremendously because lack of attention, lack of imagination, lack of adequate manpower. There's very little future for the children or for those who are in these institutions. Both need a tremendous overhauling. I'm not saying that those who are the attendants there are the ones that run the institution are at fault. I think all of us are at fault. And I think it's just long overdue that something be done about it.
It's been more than 6 years since Robert Kennedy walked out of one of the wards here at Willowbrook and told newsmen of the horror he'd seen inside. He pleaded then for an overhaul of a system that allowed retarded children to live in a snake pit. But that was way back in 1965, and somehow we'd all forgotten. I first heard of this big place with the pretty sounding name because of a call I received from a member of the Willowbrook staff, a Dr. Michael Wilkins. The doctor told me he'd just been fired because he'd been urging parents with children in one of the buildings, building number 6, to organize so they could more effectively demand improved conditions for their children. The doctor invited me to see the conditions he was talking about, so unannounced and unexpected by the school administration, we toured building number 6. The doctor had warned me that it would be bad. It was horrible. There was one attendant for perhaps 50 severely and profoundly retarded children, lying on the floor naked and smeared with their own feces. They were making a pitiful sound, a kind of mournful wail that it's impossible for me to forget. This is what it looked like, this is what it sounded like, but how can I tell you about the way it smelled? It smelled of filth, it smelled of disease, and it smelled of death. We've just seen something that's probably the most horrible thing I've ever seen in my life. Is that typical of ward life?
Yes, there are 5,300 patients at Willowbrook, which is the largest institution for the mentally retarded in the world. The ones that we saw were the most severely and profoundly retarded. There are thousands there like that, not going to school, sitting on the ward all day, not being talked to by anyone.
That was it, huh? It kind of ends abruptly. That was weird. It didn't seem quite right the way it ended. But at least that's a nice snippet. There's longer ones, but I don't know how long you guys have to do this training. That's really something I should have asked earlier. I always assume people have a 2-hour window, which is about what you can get from people, right? So we'll keep these videos short. You might be able to get an extra hour in there, but 2 hours, and take some things out if you need to, feel free to. Okay, so here we go, back to the PowerPoint. Is this the right now? Over here. Okay. Okay, so here, it was mentioned earlier, and we were talking earlier about the cocaine and alcohol exposure during gestation, right? So this is quite the reality. So many folks that are coming to us now in their 20s and 30s, it's very sad. We had the crack cocaine epidemic in most cities. A lot of people, a lot of intergenerational trauma, but there were a number of babies born addicted to cocaine during the 80s and 90s. And so these folks are actually close to 40 in some cases. And there's a very specific profile where they have severe ADHD, a real inability to focus, and they have a impulse control issue. So that kind of like similar to TBI, where there's a frontal lobe damage, traumatic brain injury. And there's, but there's a very specific type of brain damage. So the cocaine does not affect their ability to make social connections, understand things socially, be connected to other people, but it does affect their ability to focus and to be able to finish things, right? And also they usually have a lot of behavioral issues based on impulse control issues. And I have somebody that I'm working with right now where everybody's very frustrated with him all the time. He speaks very well. And so folks say, well, he's smart. He knows what he's doing. But he actually is so unable to control his impulses. And I'm so sure that he was exposed to drugs in utero. You don't always know, but he just cannot control those impulses. So we do all kinds of coping strategies and then build up that sense of self, that identity, because he looks at himself as a horrible person because he's the black sheep of the family, and he's, broken things and breaks things whenever he gets upset and is in a very agitated state a lot of the time. But I believe he was exposed to drugs. Then there's those folks where I know they were born exposed to cocaine, and we see this pattern, and the behavior plans that people have for them often do not work because they become so anxious, right? They sabotage themselves. And I can't say it's because of anxiety, it's because of a complex web of things. Some of these behavior plans that folks are put on are very controlling, and it takes their power away. And the only power they have is their behavior in many cases anyway. So they're trying to get some kind of autonomy back and assert themselves. And then there's the exposure to methamphetamines, which we're seeing similar pattern, severe ADD and impulse control disorder. And again, it's very specific brain damage. So parts of the brain are fine and other parts aren't, so people usually have good expressive language, but they don't have receptive as well. So they act like they know, but they're not really processing. Again, we have to go slower. We have to, and always be checking in. Well, what are you thinking? What does that mean to you? And really talk. But my experience of doing therapy with folks who have had I'm going to talk about alcohol in a minute, have had drug exposure, is that there's quite a yearning to be like everyone else because their social awareness is very heightened. Nothing is damaged, understanding that. Their expressive language is good, but they often don't understand things and don't want people to know because they're so aware of being the person with the disability and so don't want that stigma and don't want to be that person. So it's very tough. We're seeing the same pattern with methamphetamines. And now, many people are being born addicted to opioids. So heroin has been around forever. And my experience, I've been working with folks who were born and know people who were born addicted to heroin who actually came out okay cognitively. But we don't know about OxyContin and all these other prescription drugs and the opioids, the whole class of opioids that now babies have been born addicted to, right? Because of this opioid epidemic. So we may be looking at a similar pattern there. And it's these folks really benefit from therapy because they're so concerned and so wanting to be a part of the world because of this social awareness and because of this just real trauma that they've had and understanding so much and not wanting to be the person with the disability. I work with this one woman who used to say over and over again, why did my mother do this to me? Why would she smoke crack while she was pregnant? Why would she do this to me? It was so sad, so sad. And she ended up having an early death, which was terrible. All kinds of health issues. And, there was so many ramifications of what she was exposed to. And often people aren't just exposed to the drugs, there's often alcohol involved as well. So fetal alcohol spectrum disorder, now it's termed as a spectrum disorder. Here's the facial features, like there's a flat area between the lip and the nose. Probably a lot of you guys know this, the philtrum. The eyes are half lowered, the ears are lowered, the mouth is often open like that. But there's research that came out recently saying only 10% of the people with fetal alcohol effects, fetal alcohol spectrum disorder actually have the facial features. That all kinds of, people are affected all kinds of ways from alcohol exposure. And the main core of the effect is the lack of ability to connect cause and effect. That lack of ability to really sequentially reason. So they don't understand or process how what they're doing keeps bringing them that same effect, right? So you know how they say, well, the definition of insanity is doing the same thing over and over again and expecting different results. That's really the definition of fetal alcohol syndrome, right? Because folks can't sequentially reason. They can't get that cause and effect. And we put them on these behavior plans that are based on an understanding of cause and effect, and people don't get it. And their consequences don't work, and it makes them frustrated and angry. Coaching and supporting works in these cases, you know, giving them some tools and talking them through things and giving them that support, because they're not understanding cause and effect. Now let's combine the cocaine damage with the alcohol damage, right? So you have folks that have ability, a real difficulty focusing, impulse control issues, and then that inability to connect cause and effect. And that's a pretty common profile. I see that a lot. And they get referred to you because of behavioral problems, right? But that impulse control. But so much of the work that we need to do with them is giving them a sense of self, helping them to feel good about themselves, helping them to see themselves differently, and helping them to find ways that they can fit in socially, that they can have that life and that support. There, interestingly enough, 2014, a statistic of how many people were told that they were going to have a child with Down syndrome and aborted, what the percentage that aborted is 65%. In 2012, before then, it was 85%. So it may have gone down by now. I haven't been able to see any more recent statistics, but it's considered around 65%. So we have less and less folks with genetic disorders. And in general, we're screening for a lot more genetic disorders now through amniocentesis. So the face of disabilities has changed. You have more people that have been exposed to drugs and alcohol and less genetic disorders. This is a reality. So now I shift gears and talk a little bit about therapeutic supports, but maybe it's time to stop, have a little discussion. So anyone have anything they'd like to share? It's the tragedy of that drug and alcohol exposure is so profound.
I really like how you mentioned genetic screening has gone up. And so now more of it is the other stuff, because I hadn't even connected that. And I've undergone the blood genetic testing because I'm a cystic fibrosis carrier.
Oh, wow.
We screened that out, and I hadn't connected how much that was probably occurring now.
Exactly. Abortions. So I had one family tell me in North Carolina that the doctors, they had a positive for Down syndrome. The doctor's office called them 6 times trying to schedule an abortion. Like, people get really pressured to get abortions. I don't know why, but that's interesting and terrible. And they told me they actually had to threaten to call a lawyer and to sue them to get them to stop calling.
Well, it's interesting because to get my genetics testing, it took months, and mine was a simple blood one, but getting into the doctors, finding out with insurance, finding approved labs. And as soon as I tested positive for the cystic fibrosis gene, they immediately got my partner in. And then even getting his results, I had to keep calling. So I've definitely seen both sides of it.
Both sides. So when there's a real true diagnosis, like you have a kid with Down syndrome, and by the way, there are a number of false positives, which that breaks my heart as well. But when you've got that clear amnio, there's the push, because I've had a number of parents in Maryland, because oftentimes people will call me, they have a friend who knows me, and they'll connect with me after they find out that they're going to have a kid with Down syndrome. That's happened to me a bunch of times. And every time they say that the doctor tried to help them schedule an abortion. Same thing with spina bifida. So my friend's daughter had a baby with spina bifida, and they were at Johns Hopkins, she was pressured. So now they do in utero surgery though. So now they're getting, famous for that. Not pressuring people as much anymore because they can get famous for something.
I've heard of some European countries. I can't remember which one it was. My friend, I had just recently learned of that they really don't have any Down syndrome because they abort all of them. And my heart grieves because I feel like there's such a life. Yes, they have a difficult life, but I have seen such joy that multiplies. And it's almost like I don't know, life is, I see life, the difficulties in life often make us more appreciative. And even children who have like cancer when they're little, there's just something about adversity that actually makes people experience life differently, and that multiplies to the rest of us. And I just think that sometimes it's kind of like we don't think about that. We just think of like, oh, we don't know what could happen. But we don't know what happened to any of us. I mean, really, or any of our children that are normal. We can't predict what could happen. But yet, it's hard because at the same time we're saying we want to help them. At the same time, we're saying it's like, well, if you don't have these things that we don't, do you really want to deal with that? Well, we don't like to deal with a lot of problems, but it doesn't mean we shouldn't. I mean, I'm just saying a little.
Yeah, I agree with you totally. Like, to me, it's kind of like genocide. Like my favorite people, so many of my favorite people have Down syndrome, like the most wonderful people on the planet. It makes me crazy. I just can't bear it. I'm sorry. I try not to use that word, but I do. I have to work on that. But it makes me want to pull my hair out because, I mean, I would adopt them, and then there's so many folks looking to adopt, but I know. It is its own form of genocide in my mind, but I don't usually say that, but because, and folks have rich and wonderful lives. So one of the other that I'm going to show you probably next week as we go over it, or maybe the week after, from the reality show Born This Way. Have you guys seen that? It's folks with Down syndrome, right? It's so wonderful. And I have a snippet where this guy really opens up about how he feels about himself. It starts off about relationships, but then it kind of goes into how he feels about himself, which I think is, again, the voice of a person with a disability and really important to listen to. But, these folks are just so wonderful. And it's like just saying everybody with a big nose has to be aborted or something like that, or everybody with giant ears should go. I mean, that's as how it feels to me. It's just so cruel and random and horrible. But this is the world we live in. And I think my feeling is the more we do these trainings, the more we get the word out about how wonderful people with disabilities are, how precious, the more you have work with them and the more other people see them, the less anyone will want to do this. I think the media has helped, that we have actors and actresses with Down syndrome, that's been really wonderful. I love Breaking Bad, one of my favorites. And the son with cerebral palsy, I love that so much because his having cerebral palsy was never an issue.
Nope.
I love that.
That was such a good series.
Oh, genius, right? It was just genius. So I think that the media is helping us, and the girl who's a model with Down syndrome, and then there's a Gerber baby with Down syndrome, right? Oh, that Gerber baby, so cute. So I think we're inching along, and I think it will make a big difference doing this training, and getting therapists to just say, okay, this is normal. This will be normal. That'll make a difference.
And I think, like with any issue the therapists deal with, is that you have to kind of look at your own internal issues that make it uncomfortable or make it a little squeamish. I think that's always important to talk about, because we all have things that we were like, it's easy for us to do in our sleep, and then other things that are a little bit more like, oh wow. And it's not like that doesn't mean we don't do them. It's always about being introspective enough to look and say, what is it that I feel like I'm going to do something wrong? Do I feel like I'm going to, I'm not patient enough? I don't like to have to repeat myself. I mean, or I get uncomfortable if there's not the results that need to be there. Because I think that's sometimes what happens is that people can feel like I have a way of doing this and I have to do it slow, to expect less, or to expect that in 6 sessions I'm going to get this far instead of this far. That's something that's if someone's more rigid and thinking like how therapy should flow, then those are kind of things that kind of come up in I think what makes people feel, I'll say, squeamish, like where they get a little uncomfortable. It's like, and I think we all have to be a good therapist is to kind of challenge yourself, is to say, what is it about this? And to kind of process that with another colleague or a supervisor to kind of address, so that we can be engaging in that thing. And I think that that's something as a trainer that I will address, and to kind of hold people accountable, because I think it's so much easier to say I don't do windows than to say, I got to do the hard work of being a good therapist.
Get that squeegee out.
I don't do windows.
I love it. Me neither. That's a perfect analogy. I love that. That's really true. And it's easier rather than challenging yourself. And if we present it as a cultural competency, that this is just one more culture you're dealing with, because we're all dealing as therapists with lots of different cultures. When someone walks through your door or turns on their computer these days, right? When someone turns on their computer and Zooms with you, they're bringing the whole culture to that screen or to your office. And that we always expect we have to figure it out and adjust ourselves and learn who they are and the family stuff and the cultural stuff. And maybe we have to go educate ourselves. Like, let's say my analogy is always, if somebody comes from Cameroon, I'm not going to say I'm not trained in working with Cameroonians. I'm going to say, oh, wow, let me educate myself. Oh, there's a big conflict there right now. Are you on the French side or the English side? Or how has that affected your family? I'm going to try and educate myself, because I know I'm a little over my head. So I'll try to get the information I need, but I'm not going to close my door. So I think it's the same thing with disabilities. And this is what we're doing, we're educating people. And I think so much of just your basic positive approach is very healing and therapeutic. People don't need a high level of skill. You're talking about people that no one has listened to. People are constantly instructing them on what to do their whole life. So sitting down and listening to them is incredibly impactful. It's amazing what it does. Just active listening. I try and train the staff, the direct care staff, in active listening, because I feel like everybody needs to listen to these folks who have been marginalized, and not listened to. So I have this slide here, which talks about just begin with empathy, validation, and respect. Like, basically, I'm telling people, can you guys see this? Yeah.
Yes.
Okay, good. Little cherry blossom. Giving that empathy, giving the validation is so big. Just to listen and empathize, which we are all trained to do. Validating the experience is so giant for people with disabilities, because so often their reality has not been validated. Oh no, that staff wasn't mean to you. That's a very nice staff. That guy wasn't making fun of you. Yeah, they were, right? So oftentimes their day-to-day, life-to-life experience is not validated. Imagine that, if you're gaslighted all the time, right? If everything you ever talked about, someone was saying, no, it's not really like that. No, you're wrong. Wow, it's very tough. And that happens so much where people are told that someone didn't abuse them, or people are told that someone wasn't making fun of them, or people were told that it was their fault, not that other person's fault. I've heard 10,000 stories of this. And in the programs, you know, that's what we kind of have a whole system set up to blame the victim, right? Well, because if that person starts having behavioral issues, it becomes about them. Well, maybe those issues are related to what's happened to them and what people are doing to them. Maybe no one's listening to them, so they have to use their behavior. So the doing anything is so helpful. But, you know, I put these 3 things in to begin with, like just giving empathy, having that person just being kind and saying, yeah, wow, it's great to see you. It sounds like you've been through a lot. I'm validating their experience and showing respect. So these are kind of the 3 cornerstones that I put in there. I threw this slide in. Howard Gardner talks about, oh, I don't even have his name, but I think it's generally accepted that there's multiple intelligences, right? So Howard Gardner is the man that talked about that. And, you know, his view is that people have all kinds of intelligence. And we measure word smart and logic smart in IQ tests, and we miss all kinds of intelligence. You know, he has all kinds of terms for that, you know, interpersonal and intrapersonal, understanding the self, understanding, connecting with others. Some of the most emotionally intelligent people I've worked with have been people with intellectual disabilities who are so sensitive and so attuned. And I've seen that, and it's been really amazing. And so I kind of say to people, you know, just understand there's intelligence, assume intelligence. And it may be a different type. It may be what we're not used to. It may be this person can't express it all verbally. That's why I've had a lot of success doing expressive therapies. We ran a program where we had a music therapist, and that was really amazing. Doing art projects. I can't say that I did art therapy because I'm not a certified art therapist, but doing lots of art projects and expressing in art has been wonderful. Using the workbooks that I've shared and I will share, all kinds of things where we take a backdoor approach. And people, I had one person where she was referred to me, and she'd been sexually abused by her sister's boyfriend, but her sister did not believe her, and her father did not believe her. And she reported it to the police, but nothing happened. He didn't show up, and it was just dropped. And so this was very traumatizing to her. But she uses very few words, and we were working together on Zoom. So it was really, really tough. Should I stop sharing so you guys can see me? Let me see. So I'm making you all dizzy with all my stop, start, sorry. But so like there I was with this challenge. Usually I can like physically connect with someone, and that helps a lot, right? No, we couldn't. She's Zooming with the TV on in the background. I kept trying to get them to turn the freaking TV off. You know, staff's walking in and out. Oh, it was horrible. And I'm like, how can I connect with this woman? How can I? She wasn't going to open up about anything. And her mother had died the year before. So there, we know she had all this trauma. That's why she'd been referred. And she had that experience of being molested, and it wasn't validated. And sister didn't believe it. Father didn't believe it. And then they were mad at her for calling the police, or she told the staff and they called the police. And then it was all dropped anyway. So she felt totally invalidated. She had the death of her mother. And so I said, okay, you know, what were some of the things you did with your mom? Because she was starting to talk a little bit about her mom and her mom. She missed her mom. I miss my mom. And not using a lot of words. What did you and your mom do? Did you like music? Did you loved country music? I am not a big country music fan, but that's okay. So I found some country music, and then we just found other music, you know, just right. And then she just started singing. And I showed it on YouTube on my sharing screen. And oh, we would hit a song that she used to sing with her mother, Dolly Parton, 9 to 5. We listened to it over and over again. And then Whitney Houston, who knew? I love Whitney. But, you know, we started singing and she would sing and then we'd stop and she'd talk. And then, you know, some of the Disney video songs, Can't Stop the Feeling, she would sing and dance in her seat and then talk and open up. It was so amazing to me that I was just so stuck and on such a dead end with this work, trying to do it through Zoom, and this music opened her up. And I've done that with other folks where, you know, we've done an art project or we're, you know, they're mourning someone and said, okay, let's do a memory box. Let's decorate a box and put a message to that person in, and they just open up and decorate it and interact. And these projects just like activate them. So sometimes using different modalities helps a lot. But understanding, back to the screen, that this person is, you know, very, okay, you know, complex. So people aren't more simple who have disabilities, and this is something we want to communicate. They're actually more complex, and they have different types of intelligences, and you don't know what the key to them is going to be. With one group, we started doing yoga, and some of the guys didn't want to get out of their seat and were worried and didn't want to. We did chair yoga, and people started opening up. We did it in group, and then we did it before we would have our group session. And that really opened people up. I do 3 groups now on Zoom, and that's been amazingly effective. Yeah, everybody talks over each other and it can be total chaos, but it's also wonderful. And a bunch of people have connected and become friends, and they really protect each other. So people are smart. They're smart on such different levels. Assume intelligence. Always assume intelligence. And when we look at post-traumatic stress disorder, we can see it as a spectrum issue as well, because people may not be presenting as totally traumatized, but they may have certain symptoms that have been identified as a behavior problem that are really PTSD. So they may not be totally severe or totally shut down or completely dissociated, but they've got it, and they've got it in different extents. And sometimes we see the behaviors we see are really those symptoms of post-traumatic stress disorder. So I've had a number of people referred to me because there's a behavior problem. And then that behavior problem turns out to be a symptom of post-traumatic stress disorder, that they're hyper aroused or they're hyper vigilant or they're, you know, totally shut down. And so they're non-compliant, quote unquote. You guys are so supportive. Thank you. And thank you, Mary, for that slide. Thank you so much. I'm so excited. You're a precious group of people. So I don't want to start the next round, which is I'm breaking down the symptoms of PTSD. And, you know, we can evaluate afterwards what you think you might want to get rid of, or maybe it's too much about trauma. But honestly, I think most therapists these days are very aware of trauma, right? And if we go, and my feeling is trauma is the front and central issue in the disability world. And that's kind of what I base my life on, you know, is standing up for that and saying these behaviors are symptoms, they're not the problem. But so if you, I mean, maybe we can discuss that too, but I feel like trauma is a good door to walk through in this training because it's everywhere and people are already familiar with it. And now maybe they'll see, okay, working with a person with disabilities is like working with someone with trauma. And so I can take these tools that I already have. So in this training, I will tell people about what I do. Like I'm a big EMDR person, I shared earlier in the training, but I don't push that when I train therapists because I want them to feel as comfortable as possible to use whatever they do. You know, just do what you do. and try to modify it or adapt, meet people where they are. I'm going to start saying that from now on. That's so much better than go slower to lower. But I like saying that because it rhymes, slower, lower, but I won't say it. I'm going to say meet people where they are. But honestly, take your tool bag and see what works, adjust it like you would with anyone, right? Like you would with anyone. And when you're working with someone that you know has trauma, you're a little more gentle, right? You tread a little more lightly. You don't go running into that trauma. Let's talk about, let's process it, right? You figure out where they're at with it. You know, you spend a little more time building that rapport and that connection and getting that trust established when you know you have someone who has severe trauma, right? So I think we can convey to people, assume that trauma, you know, assume that that's there. And so you're going to be gentle and be aware and be very trauma focused. And then I found so many therapists have so many tools when it comes to trauma. Like a lot of people are doing TFCBT and, you know, there's all kinds of things that folks are being trained on and folks are doing and, you know, DBT and, you know, so many things that they're using and that can be modified very easily by taking the time. So next time then we'll pick up with the symptoms of PTSD and you will have the slides, which I'll probably keep changing anyway, but I'll send you the slides because we always keep changing them because you guys have important input. So that's it for me for today. Have a wonderful week. I can't wait to see you all next week.